I'm Mary Pachalski, one of the neonatal nurse practitioners. Welcome to the call room. I'm going to spend a few minutes here today going over a new process for the assessment and treatment of infants with neonatal abstinence syndrome. I'm hoping that by the end of this, you'll not only understand the problem, but you'll understand why we need to approach it in such a different way. So you've all heard about the opioid crisis in the United States. I think the statistics are staggering, especially the number of people who misuse prescription opioids. When I look at all of this, I think about not just the number of people who this involves, but also the number of people who are dying from it and the cost to the healthcare system. I think it is something we should all look at very carefully. I think many of us have been touched personally by some of this issue, and we all should be sharing our stories about what that was like and thinking about how can we make this different, better going forward. So we call it the opioid crisis for a reason. It's because all of the drugs involved in it are under the category of opioids. And we'll talk a little bit about what an opioid is in a minute. But this encompasses illicit substances such as heroin, treatment medications, methadone and buprenorphine. Two of the brand names for buprenorphine are Suboxone and Subutex, and then a plethora of prescription medications such as Vicodin, oxycodone that are opioids. And then there's a subcategory of the prescription opioids, and that is diverted prescriptions. So prescriptions that are either obtained illegally, somebody is selling their prescription to someone else, they're going in somebody's medicine cabinet and stealing these, and sometimes the drugs are being compiled and distributed from different sources. The current evidence suggests that the most common cause today of heroin abuse actually started with prescribed opioids for pain. So people got pain relief from their opioids, they took them on a regular basis just the way they were prescribed, and then when they continued, they no longer had the pain but kind of got addicted to using those opioids. They then started to obtain them from legal methods. And interestingly, many people went to heroin as a substitute because heroin's much cheaper than any of those drugs. So opioids, why do they do what they do? Opioids are drugs that bind to special receptors, opioid receptors in the brain, spinal cord, and other areas of the body. Some of them are called the mu receptors, but there's other receptors in addition. So what they do is when they bind with these receptors, they reduce the signal of pain messages to the brain and curb those feelings of pain. The problem is prolonged use of opioids results in adaptation of those opioid binding receptors, causing a biochemical changes in the cell itself, which results in, first of all, increasingly higher doses of drugs required to achieve the intended effect, that's called tolerance, and then adaptation of the cell itself to the presence of the drug, which is called dependency. When a dependency-inducing drug is suddenly discontinued, withdrawal occurs. Withdrawal is a physiologic reaction of the body missing the drug, the symptoms of which are exactly the opposite of the effect of the drug itself. Addiction, however, is a chronic progressive disease. It's a treatable disease that involves both physiologic and psychological dependency on psychoactive substances. And they induce drug-seeking behavior, despite the physical or psychological harm to the user or to society. The opioids rapidly diffuse across the placental membrane into the fetal system. Thus, she transfers that opioid to the baby, to her fetus. And when the fetus experiences continued exposure to those opioids, they then also become dependent on it. So substance abuse is one of the most frequently missed diagnoses in perinatal medicine. And in addition, maternal opioid use is now one of the leading causes of maternal death. We first started focusing on the opioid crisis around 2012, a little before, but we now know that this is an epidemic so great that about one baby is born every hour who has been prenatally exposed to opioids and will have some symptoms of withdrawal. This only accounts for the babies who are diagnosed and coded as. Once that placenta source of the opioid is cut off, the infant goes through withdrawal. So neonatal abstinence syndrome is a withdrawal syndrome. It's the constellation of clinical findings that's associated with withdrawal after prolonged exposure to opioids in utero. And it's very specific to opioids. So there's other drugs that can cause a withdrawal syndrome. Babies who've been exposed to SRIs in pregnancy often will have some symptoms of withdrawal. Certainly babies who have been exposed to cigarette, tobacco, smoke have some symptoms of withdrawal. Cocaine babies have symptoms of withdrawal. None of those are neonatal abstinence syndrome. They're a separate withdrawal syndrome. But it's important to remember that it doesn't happen in every single baby exposed to opioids. So the studies have shown that it's about more than 50% in the upper 90s. And the presence of the symptoms are presence of the physiologic dependence on opioids. So it's that neurochemical reaction to the depletion of the drug from the CNS opioid receptors. The most important takeaway point from this slide is babies are not addicted. They don't have drug-seeking behavior. And we need to be very careful when we're talking to their parents that we don't use that word addiction in reference to the baby. The babies are opioid exposed, and they certainly have some dependence, and they can experience withdrawal, but they're not addicted. So the symptoms of withdrawal that we see, as I said, result from those opioid receptors kind of missing the presence of the opioids on, and then the release of neurotransmitters that cause the symptomatology that we see. As you look through this list, so stress, hyperphagia, which is a baby who wants to eat all the time, tremors, tachycardia, vomiting, diarrhea, yawning, seizing, sweating, some restlessness and decreased sleep. You notice that all of these are CNS or gastrointestinal symptoms, and that's because the predominance of opioid receptors are in the CNS and the gastrointestinal tract. In 2017, the Illinois Department of Health commissioned the NES Advisory Committee that reported to the legislature, who met, and I was on this committee, who met and tried to quantify the problem of neonatal abstinence within the state of Illinois. Then the Regionalized Perinatal Health Program, other stakeholders, along with the Illinois Perinatal Quality Collaborative, implemented a statewide initiative for the obstetric and neonatal teams all across Illinois birthing and newborn hospitals to improve the quality of care provided to mothers and newborns affected by opioids. It was called the MNO Initiative. There were two teams, one addressed obstetrical care and the other addressed neonatal care. But the objective was to develop and implement an NAS quality improvement initiative that was similar to the work that was done in other states, and then it was adapted for use in Illinois. When we looked at the rate of neonatal abstinence syndrome in the state of Illinois, we discovered that it was not at all inconsequential, and in fact, there was a 52% increase in NAS between the years of 2011 and 2006. So that's 52% in just 5 years. So we knew that we had to do something and do something big. And that's what ILPQC has been working on for the past 2 years. As part of this initiative, we looked at what is the best way to assess and treat infants with neonatal abstinence syndrome. As a bedside nurse, one of your responsibilities is to assist in the identification and symptoms and quantifying the symptoms of NAS. And this is done through a scoring system. You want the scoring system to be clinically valid and reliable and to measure abstinence, not measure something else. And the purpose is to determine the infants that need treatment. So it's intended to be a systematic, objective evaluation of the newborn, and it helps everybody use the same language to quantify the severity of the symptoms and provide guidance for pharmacologic management. Currently, everybody, probably most everybody across the United States was using, I don't want to say currently, so previously, almost everybody in the United States was using the modified Finnegan tool. So the Finnegan was developed in the 1970s by Loretta Finnegan, a pediatrician. I think she worked in Philadelphia, and she had a nursery where there were a plethora of heroin babies of mothers who were addicted to heroin. And what she tried to come up with was a way of quantifying which of these babies was going through withdrawal severe enough to require some treatment. Now remember, this is the 1970s, so it's an entirely different system of perinatal care, especially with regard to mothers and babies. Babies all went to the nursery, they came out, periodically with their mother to feed with their mothers, but they often went to the nurseries at night and in between that. Now, the Loretta Finnegan chose the number of 8 as the threshold for treatment, babies needing treatment with morphine, because she kind of felt like those were the babies whose withdrawal was really the most severe. Over the years, that has just kind of been adopted, although she did one study. The Finnegan tool was never actually validated in any clinical study. And over the years, I looked at this during my doctoral degree, and there are somewhere around between 5 and 8 different forms of the Finnegan scale that has been used in different studies. The indicators identify opiate withdrawal in the term infant, but the problems with the Finnegan there's a plethora of them. For one, the reliability of that tool is highly dependent on the training. So it's not easy because there are so many indicators, at least 21 in the most current versions of the tool. When you look at all those indicators, it's hard to decide which one of those is the most important. Which one is going to, if you use the scoring system, one sneeze can take a baby from a score of like 6 or 7 to a score of 8 and require treatment. So pharmacologic treatment is based on an assigned number. It's not based on really what the baby was like, because many of the symptoms can be unrelated to the infant's function or comfort. A crying baby can sound like a withdrawing baby. The way the Finnegan was taught is you were taught to take a baby, wake them up every 3 hours. Oh, and they had to sleep for 3 hours, which Remember, these are otherwise normal newborns. How many of them sleep for 3 hours at a time? Not many. Um, anyway, so you took this sleeping baby, then you unwrapped it, and you did a moro because you wanted to see like how big the moro was. And then you expected this very disorganized baby, because these are babies that are exposed to opioids and are going through withdrawal, to calm down and eat well. Well, all of this kind of is counterintuitive to the way we treat a newborn baby, because waking them to score them interferes with the rhythm of the demand feeding in the newborn infant. And it doesn't make any sense to take a baby, as I said, who's disorganized by baseline, and see if we can get them more disorganized and then get them to calm down. So a very smart pediatrician took from the East Coast, saw this process of scoring babies and said, might there be a better way? Might there be a way to treat these babies like newborn babies instead of like sick infants? When we're assessing babies for NAS, we have to really know what's the most important clinical signs of withdrawal. So clinical signs that a baby is really having severe withdrawal is a baby who is crying and unable to be consoled by holding them, by rocking them, by giving them a pacifier, by feeding them. A baby who sleeps less than an hour. When I've held these babies, they can, even when you're holding them tight, you can feel them kind of startle at times. So those are babies that are sleeping poorly. So babies that lose more than 10% of their birth weight, a baby who is unable to coordinate a feeding within 10 minutes or is unable to sustain breastfeeding for 10 minutes, babies who puke, and not just spit up, but puke, like hit the wall vomit. Of course, diarrhea, and diarrhea is a watery stool, not loose stool. Breastfed babies almost all have loose stools, but you're looking for that ring of water around the stool. And then tachypnea and fever, of course, being careful that that's not a symptom of an infection. So we have to focus on the symptoms of withdrawal that we can change, and these are some of them. So Dr. Matthew Grossman was that smart pediatrician. He was out of Dartmouth, and he said, maybe we are expecting too much of these babies. Maybe we're trying to fit them into a category that they don't need to fit into. Maybe we need to instead think about these babies acting like babies. So what do newborn babies need to do? They need to eat, they need to sleep, and they need to be consoled. So maybe not every baby who has withdrawal needs treatment with an opioid like morphine. Maybe if we started to see if they were functionally able to be a baby, we could avoid treatment and then avoid some of those long lengths of stay. So when we're focused on eating, we want to see if a baby can breastfeed effectively for at least 10 minutes or feed 10 mLs by bottle, or whatever the current age-appropriate volume would be. We would be concerned for significant withdrawal if the baby is unable to coordinate the feedings within 10 minutes of showing hunger cues, and or is unable to sustain that feeding for 10 minutes or breastfeed or feed 10 mLs. Now remember, when we're looking for the baby not doing what we're expecting them to do, we want to think, are they not doing this because of opioid withdrawal symptoms, Or is there something else? If poor eating is due to non-NAS factors, like maybe the baby is a late preterm baby, maybe they have some transitional sleepiness. Remember that sleepy period after the first, in 2 to 4 hours after birth? Or are they spitty? Just because a lot of babies are spitty, or are they unable to latch because of the mom's structure of her breast? Does she have flat nipples? Is the baby tongue-tied? So we have to really kind of critically think about how we are saying this baby is unable to do it. They've been exposed to opioids. That's why we're concerned about them, or potentially exposed to opioids. But is there symptoms related to that, or are there symptoms related to something else? When we're evaluating the baby's sleep, we're looking for them to sleep for about an hour, not 3 hours. That's kind of the category that we put premature infants into. Now, think about this in the context of what you would do for any other mother. If you have a newborn baby who hasn't eaten for 3 hours, and especially if they're breastfeeding or if they took a very small volume of formula at the last feeding, you are going to wake them up at the 3-hour mark. That's just good nursing sense, right? So remember, we're looking for them to sleep about an hour, at least an hour after a feeding. Now, we would be concerned about symptoms of withdrawal if the baby is unable to sleep for an hour after a feeding because of opioid withdrawal symptoms. So they're fussy, they're restless, they startle awake, they have tremors. It's not applicable if they're not sleeping because of non-opioid related factors. For example, physiologic cluster feeding, as many breastfeeding infants do in the first few days of life, or interruptions in sleep for routine newborn testing. So we're waking them up because we have to draw the PKU, or symptoms in the first day that are likely due to nicotine or SSRI withdrawal. So again, it's always thinking about they weren't able to sleep for an hour, but why was this? Was this because of opioid withdrawal syndromes, or was there some other factor? And the same goes for consolability. So a baby who is unable to be consoled within 10 minutes, you have concern that they have significant withdrawal. So no matter what you do, they're crying, they're grimacing, they have distress while they're being held. Also, if they cannot stay consoled for at least 10 minutes due to opioid withdrawal symptoms. And when you see the word NPI on here, that's non-pharmacologic interventions that we're going to talk about more in just a few minutes. Of course, it's not applicable if any of their inconsolability is due to non-opioid related factors, like the baby's been crying and we didn't get it because they're hungry and we didn't get there to feed them right away, or maybe they have circumcision pain if it's a little boy. Non-pharmacologic interventions are universally recommended in the literature as the first-line treatment for all infants at risk for or who have NAS. And it's an essential part of the ongoing management, including those that require pharmacologic treatment. It's all about hugs before drugs, and I love that saying. The categories of non-pharmacologic treatment fall into developmentally supportive care, family engagement, and appropriate feeding strategies. We have to think about non-pharmacologic interventions as equal to medication for these babies. So rooming in is one of the foundational concepts of eat, sleep, console, and using that approach in the treatment of neonatal abstinence syndrome. It supports a number of things. First of all, it's the premise that the mother is the treatment for the baby. So her presence is the best way, the best thing in helping the baby coping with the symptoms of withdrawal. It also supports her learning the baby, so she has the opportunity to understand what type of withdrawal symptoms her baby has and which of the interventions work best with her baby. One of the primary things that we want to teach them and practice ourselves is early intervention to crying. So these babies are very sensitive to stimuli, and the more stimuli they get, the more wound up they get, and the more they escalate in their disorganization. So once they start crying, if we can attend to them very quickly, which is why we want the baby in the mother's room so that she can do that, we certainly can help prevent that escalation and hope to keep the baby in control, and so the baby is able to eat, sleep, and console. We want to feed the baby on his own schedule, not our schedule. Think about clustering care so that we can allow for uninterrupted periods of sleep. And demand feeding. We don't have to wake them up every 3 hours. They can sleep 4 hours, but maybe the baby wants to eat every 2 hours. So eating every 1 to 2 hours is a normal pattern in a breastfeeding baby in the first few days of life. Then skin-to-skin contact and breastfeeding certainly promote bonding. So these are kind of the really foundational aspects of eat, sleep, console approach to caring for infants with neonatal abstinence syndrome. We want to optimize the baby's success with feedings. So we want to feed at early hunger cues and feed them till content. There's no limit on the volume or the duration of the feeding. We talked about every 3 hours earlier because that's 8 to 12 times a day is what we would expect any newborn baby to feed. Also think about feeding them early when they show signs of hunger cues, and then maybe stopping in the middle of the feeding to change their diaper, because that can cause some escalation in their symptomatology, and then some may have trouble settling down so they can coordinate during the feeding. Pacifiers are certainly appropriate, and they can be used if a baby feeds well and for comforting between feedings. Be sure we evaluate how well the baby is doing in coordinating suck and swallow without excessive gagging or spit ups. We have to be smart about looking at the nipple flow rate, modifying the position of the bottle if the baby's bottle feeding to control the flow, and use all the techniques that we have in our repertoire, including consulting speech if the baby's having issues with feeding. As for any other baby, breastfeeding has multiple advantages, including bonding. Mom learns how to be with her baby. It increases those loving behaviors. It enhances her confidence. And the little bit of if she can breastfeed as long as she's in a treatment program or under a physician's care. Maybe she's on prescription opioids for pain syndrome, and as long as they are supervising her drugs and she's not using illicit drugs, there's no reason why she can't breastfeed. Contraindications to breastfeeding, of course, are illicit drug use. Many women who use illicit drugs are using many drugs, so that's another thing to consider. And then moms who are HIV positive. When you assess a baby who's breastfeeding, you're going to do the same type of assessment you would for any baby. You're going to make sure that they are latching deeply and comfortably, that they can sustain active sucking with only brief pauses, and look for difficulties with feeding and help mom through that. Certainly, lactation support is very important for these babies, and as I said before, speech therapy can also be helpful. Swaddling is one of the oldest interventions that's been used for babies. It certainly is a comfort measure, but swaddling should not be a restraint. So think about how tight your swaddle actually is. It does decrease stimulation, it helps decrease crying, and it certainly promotes sustained sleep because it helps babies to self-regulate. When they're in the womb, when they move, they run into a barrier, which is the wall of the uterus that brings them back to midline. And so swaddling them kind of emulates what they felt in the womb regarding movements and contained movements. It helps to keep them. Remember, when you swaddle them, you're going to swaddle with their arms close to their body, their hands to midline, and their feet pulled up. You never want to swaddle with arms straight or legs straight because that can cause difficulty later on in muscular and neurologic development of the extremities. Experts have found that infants with NAS really respond to being put in what's called the C positioning. So holding infants with their heads a little bit tucked down, their feet pulled up, their back rounded, seems to be an extremely comfortable position for them to be in. You can hold them either close to their body or facing away from you, and then rocking them vertically, so up and down versus back and forth instead of horizontally, seems also to be a better vestibular stimulation for these disorganized babies. I've used this intervention with many babies, and it actually is quite interesting. It works well. So when you're holding the baby in the C positioning close to your body, you pat their bottom in a very rhythmic, use your cupped hand in a very rhythmic fashion. And it just is this gentle rhythm of patting them that really helps to quiet and calm them. I'd like to accompany that with the shushing sound. So shh, 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 shh. You can also do that while they're laying in the crib, kind of on their side, and pat their bottom there. Because these babies are so active, skincare is critically important. So making sure they tend to like rub their feet together, rub their hands against their face, make sure you look for excoriation in those areas where they're rubbing. Put Aquaphor on it if appropriate, if it's not in a place where they're going to suck it off. Also, if they're rubbing their heels together, you could put a piece of Tegaderm on that to protect it. Cover their hands with gloves or little mittens if they're excoriated. Keep all that damaged skin very clean. Avoid lotions that they might suck off. And then diaper care is another thing that's really important. So liberal use of the skin protectant, petrolatum or Vaseline, Aquaphor, and certainly zinc oxide if the baby's bottom starts to get red. treat diaper rash aggressively, initiate zinc oxide early, and move on to Desitin Max if it is not getting any better. Babies like these need to have butt baths once a day. That should be part of their routine diaper care. It should actually be part of routine diaper care for any baby, but routine butt baths to cleanse the skin, drying it completely, putting Aquaphor or Vaseline or Aquaphor on at every diaper change. Aquaphor really is just expensive Vaseline. And then using Desitin or some other zinc oxide based diaper rash ointment if they start to look like their skin is getting irritated or there's breakdown. So parents, as we talked about, are one of the most important things in this philosophy of care of Eat, Sleep, Console, because we have to really help the mother to understand that she is the treatment for her baby. So we're going to partner with them. We're going to encourage parental presence and rooming in because it is associated with a shorter length of stay and less treatment and thus lower costs of hospitalization. We're going to start with a really non-judgmental approach. Realize that we all have biases and opinions about this particular problem in the United States right now. Then put that aside and be the professional, caring nurses that all of you are. So be respectful without condoning her illicit drug use if mom was using illicit drugs. We often don't really understand addiction if we haven't experienced it in our own family, especially if we haven't experienced it in our own family. We want to show empathy and build trust. And remember that fatigue is a major trigger to relapse in these women. So realize that when the mother sees symptoms of withdrawal in her baby, that may trigger guilt in herself. Nearly every mother I've talked to, whether her baby was exposed because she was taking heroin or because she was in a methadone program or because she had a pain syndrome, they all have sat and watching their baby brought tears to their eyes because they knew what their baby was feeling, first of all, and secondly, they all told me, I'm so sorry, I never meant to make my baby experience this. But it's our job now to help them through that. So we don't want them to feel judged by us, because then they're not going to trust us and they're not going to let us help them help their baby. So we want to use the right words. This baby is not addicted. Never use that word. But the baby was born exposed to opioids in utero. And remember, as I said before, not all of these mothers have a substance abuse disorder. Some of them were taking pain medication for a pain syndrome. Our job is to help them connect with their infant. So help review. You're going to take the newborn care diary that you'll see in a few minutes and go through it with them because they're going to be filling this out. This is the way they're partnering with us in caring for their baby, identifying the signs of withdrawal in their baby, and what of the non-pharmacologic interventions work with their baby. And is their baby coping with the withdrawal, helping them, working with us to assess that, or is their baby having trouble and do we need to reevaluate the approach we're using and bring in some other non-pharmacologic intervention that maybe wasn't instituted in this particular baby. All of the things we talked about earlier are important in talking to the baby, talking to the mother about the non-pharmacologic interventions, especially the feeding, the diaper care, and then work with her to develop a plan of care to help her baby. remember, this is a new mother who's just given birth. So all of that postpartum stuff that happens with everyone else happens with her too. She's exhausted. They don't call it labor for nothing, right? So help her to identify support people. If the father isn't involved, maybe it's a mother, a grandmother, a sister, an aunt, people who can come in and help her hold the baby. This baby will need to be held much more than any other baby. And having people rotate through holding them, first of all, develops a sense of community in that family. The mother starts to identify support people that can help her when she's going home, as well as while the baby's in the hospital. And then I just want to re-emphasize teaching her safe sleep is critically important, again, because these babies are at increased risk of sudden infant death syndrome, and also teach them about eliminating exposure to passive smoke, which can escalate their risk. Thanks for your time and attention. I hope I've helped you in some way understand a new approach to and a new way of thinking about neonatal abstinence syndrome and about how you should assess and treat these babies. I think we all have that opportunity to make a difference in the lives of these families and infants, and to apply the evidence we have in a consistent, thoughtful way to care and nurture the family to provide the best possible outcome. Please let me know if you have any questions about anything I've said today. You certainly know where to find me. I'm in the NNP office or on the phone if I'm here. My phone number is in the NNP office. Feel free to text me. You can also email me. My personal email is marynp@gmail.com. I'd love to hear if you have questions or concerns. Following up on this video, some of your nurses who are experts are going to go over all the paperwork that's involved in taking care of these infants. You'll have cheat sheets on all of the non-pharmacologic interventions. They'll teach you how to work with families and filling out that care diary that they're going to use at the bedside, how to chart Eat, Sleep, Console, how to wrench the thing into your flow sheets. There's a breastfeeding sheet that kind of it's like a stoplight sheet that shows what green is what drugs are fine to breastfeed with, or yellow is drugs that we should kind of think about whether we should allow to breastfeed, and they should stop altogether. There's also a number of 2 brochures that have been developed for families of these infants, one to be given either prenatally or when they're admitted, that talks just about neonatal abstinence syndrome in very general terms. And then there's another brochure that goes through all of the non-pharmacologic interventions specifically written for parents. So look at all the tools that you have at your disposal here. Certainly ask questions, reach out to the special care nursery nurses because they are the experts in caring for these infants and understanding how to apply the non-pharmacologic interventions in the best way possible. And as I said, if you really have a question, find me, call me, text me. I'm happy to help you out anytime. Have a great day. Bye.